So very much like, say, type 2 diabetes, with prediabetes, we have to think of the risk of hypertension or high blood pressure in terms of different levels. And that's what this little diagram is showing. So along this way, we see that we have increasing blood pressure. So there's high normal, grade 1 hypertension, grade 2 hypertension, and grade 3 hypertension. And so we also have to take into consideration the other risk factors. So RF being risk factors, 1 to 2 risk factors, more than 3, chronic kidney disease, uh, stage 3 diabetes, other diagnoses, symptomatic cardiovascular disease, stage 4 kidney disease, so on and so forth. So, what are these other risk factors? Well, one of them is simple obesity. So, recall it's a BMI greater than or equal to 30. But even more specifically, we are worried about abdominal obesity. So, for men, that's a waist circumference greater than 102 centimeters. And for women, that is a waist circumference greater than 88 centimeters. But unfortunately, these are only really validated in white populations. So those are kind of our anthropometric risk factors. For medical history, or just biological history, simply being a guy is a risk factor. So say you are a man, you have high to normal blood pressure. Being a man is one risk factor, and if you have a large waist circumference, that's 2. So you're still at low risk, but pretty much one other risk factor puts you low to moderate. Okay, so then if you're a man and you're greater than 55 years old, you may, by virtue already of being a man over 55 and with obesity, you already are in this 3 risk factor group. Another common risk factor is smoking and a family history of premature cardiovascular disease. And premature means for a man, it's having cardiovascular disease, or a man in your family having cardiovascular disease under 55 years, and for women, 65. Other medical history related risk factors are ones related to the cardiovascular system, including cerebrovascular disease, ischemic stroke, cerebral hemorrhage, and transient ischemic attack. Just the more general coronary heart diseases, so myocardial infarction, angina, myocardial revascularization with precuneous coronary intervention or coronary artery bypass graft. And then just the general heart failure, including heart failure with preservation of ejection fraction. And symptomatic lower extremities or peripheral artery disease. So this is often due to high cholesterol, or advanced retinopathy, hemorrhages, or exudates, papilloedema. So both these symptomatic lower extremities and advanced retinopathy are also symptoms of type 2 diabetes. So if we have uncontrolled type 2 diabetes, we basically are already at the 3 risk factors. So I mentioned high cholesterol. Well, if we look at the biochemical risk factors, dyslipidemia is a big one. And keep in mind that all of these risk factors cluster together. Often, if you have dyslipidemia, you're going to have obesity. You may also already have type 2 diabetes. And then you probably also have high blood pressure. And so that makes your risk for, cardiovascular disease even greater. So for dyslipidemia, we become concerned when total cholesterol is greater than 4.9 millimoles per liter. And this is often accompanied by a low density lipoprotein cholesterol greater than 3 and a low high density lipoprotein cholesterol, so less than 1 in men and less than 1.2 millimoles in women. And we often see high triglycerides as well. We also will be concerned if plasma glucose is between 5.6 and 6.9. This is our prediabetes to diabetes range. And then, of course, an abnormal glucose tolerance test. Uh, so having a plasma glucose, this is plasma glucose. Sorry, not HbA1c. So this isn't, they just happen to be very similar in numbers and ranges. Um, whoops. But an abnormal glucose tolerance test, again, this is going to be indicative of diabetes, which if you have diabetes, and have high normal blood pressure, you're already at that moderate to high risk. And then everything just increases from there. So chronic kidney disease is also something that's going to increase risk of death in conjunction with high blood pressure. If we're seeing protein in the urine, microalbumin in the urine, or if the albumin to creatinine ratio is between 30 and 300, and this would be on a spot urine test. So fasting plasma glucose greater than 7 millimoles per liter on 2 repeated measurements would also be indicative of type 2 diabetes, but also a high risk factor. An HbA1c greater than 7, so again, type 2 diabetes. Or a post-load plasma glucose greater than 11 millimoles per liter. And then finally, in the elderly, having a high pulse pressure is a risk factor. Having an electrocardiograph with left ventricular hypertrophy, or an echocardiograph showing left ventricular hypertrophy. And then, of course, the carotid wall thickening, this is going to go hand in hand with the high cholesterol. And then we will often see carotid femoral pulse wave velocity elevated. The ankle to brachial index will be low. And so you may not have heard of the ankle brachial index, but it is a measurement of peripheral artery disease. And it sounds like what it is. Our brachial artery is up in our arm. So we're taking blood pressure at the arm and then at the leg. So recall, if this is low, we have a problem, less than 0.9. So with no blockage, we'll see a 1 or a 1 to 4. So remember that this is a index, and it's a ratio. So 1 is pretty normal. 1.4 would mean that it's even better. But this a number in this range suggests that you don't have peripheral artery disease. Um, Borderline blockage is a 90, a point 0.9 to a 0.99. This range indicates that you have borderline peripheral artery disease. And then if it's less than 0.9, this is diagnostic of peripheral artery disease. You'd probably need more testing, such as an ultrasound or an angiograph, to view the arteries in the legs. And so with peripheral artery disease, we have to be aware that these people are at risk of blood clot problems, and other vascular diseases. So there's a pretty good website called heartscore.org. In fact, let's see if I can get this open on here. Heartscore.org. And so this is just a very simple website that will calculate the 10-year risk of a fatal or non-fatal cardiovascular disease event in your patient. So let's see which risk model applies in our country. And this was developed by European scientists. Let's see, Europe, very high risk, low risk. Oh, this is by area. Okay. We'll just find the UK and say that we're pretty much the same as the UK. I'm probably just missing it, but I see Ireland here, so we'll go with that. All right, so what you would then do is put in your patient's birthday. I'm going to put in my own birthday. Please don't judge me. Female. I'm not sure what my systolic blood pressure is right this minute, but it's usually hovering around 118. I don't know what my cholesterol is either. I'm just going to guess. But you would know these things, so then you would put them in. And I don't smoke. So by the made up numbers that I put in, low risk for myself. But if you had, say, a patient's data, you could put that in and get a much better risk guideline. All right, let's go back. So the problem with high blood pressure is it's a silent killer. The only way to detect high blood pressure is to measure it. Most people don't feel high blood pressure. So what is the recommendation? The recommendation is that adults 18 years or older without known hypertension are screened. So get your blood pressure measured. So the screening, getting your blood pressure measured. Ways to measure blood pressure outside of the clinical setting. So you can measure it outside the clinical setting. You would be possibly wearing an ambulatory blood pressure device. So that's a programmable portable device that automatically takes blood pressure measurements, usually in 20 to 30-minute intervals, while people are going about their normal activities. People may have a home blood pressure monitor. But it is important that blood pressure measurements should be taken at the brachial artery in the upper arm with a validated and accurate device in the seated position after at least 5 minutes of rest. And the optimal screening is every year for adults 40 years and older, and every 3 to 5 years for adults 18 to 39. So this is just a summary of the rationale. So an initial one-time screening with a office blood pressure measurement has adequate specificity, but low sensitivity. So it's specific, it can measure, but it isn't very sensitive. So it often will not get a true positive. They also, the USPSTF, which I don't remember what that stands for right now. It's like some group of doctors, found adequate evidence that an initial positive screening can be confirmed by at home blood pressure measurements. So you may have an abnormal screening at the doctor's office, and you can confirm that abnormal measurement at your home. And this task force found that screening for hypertension with office blood pressure measurements and treatment of hypertension substantially reduced the incidence of cardiovascular events. So this is a lot like a lot of the issues we see. Type 2 diabetes, we're able to actually get that into remission, but only if we're able to detect it early. But one of the problems with blood pressure is that when people are nervous, it changes their blood pressure. And often people are nervous at the doctor's office, and that will cause their blood pressure to go up. And this is what we know as white coat hypertension. White coat hypertension is when blood pressure is elevated at the clinic, but normal when it's ambulatory or at home. And clinical blood pressure can be up to 5 millimeters of mercury higher than ambulatory in the general population. But even if this elevated blood pressure is only at the doctor's office, it may still be prognostic of future hypertension. So it's still a risk factor. On the other hand, masked hypertension is the opposite. The blood pressure looks normal at the clinic, but is high in non-clinical settings. And this happens in about 15% of the population. And what's important is that both of these are associated with poor cardiovascular outcomes. So hypertension that is white coat, so it's only elevated at the office, or that is masked, which is normal at the office but high elsewhere, both are associated with cardiovascular disease outcomes. So we're going to take a moment to look at forest plots. And we're going to do this because the forest plots are ways that scientists can gather a bunch of data from previous studies called meta-analyses, and then they can visually describe the risk of something. So there's three main things that we need to now think about when reading a meta-analysis. The first is the heterogeneity. And this can be heterogeneity in anything. And heterogeneity means difference in something, that a population of something is not similar. So the differences could be in the results, the methodology, or the study populations used in the included studies. We also need to look at the pooled result, the overall combined result derived from combining or pooling the individual studies. And finally, publication bias. Although the intent of the meta-analysis is to find and assess all relevant studies, sometimes this isn't possible. Some studies can be missed because they're not written in English or because they show non-significant results. And things with non-significant results have a lower chance of being published. So this is how to read a forest plot. Unfortunately, this example is with Harry Potter characters, but we'll just ignore some aspects of Harry Potter. But basically, the first column is the study IDs. This is who did the studies. The second and third columns are the intervention group and the control group. And you'll see that there's N out of N, meaning how many people were in the intervention group out of the total groups. Column 4 is the relative risk. Sometimes this is an odds ratio, and sometimes this is a mean. It's important to note that if we're using an odds ratio or a relative risk, it's a ratio. So there's a number over another number. And if there's no difference between the top and the bottom numbers, it will equal 1. That's why this line is on 1. If we're using a mean, it means we're looking at some number minus another number. If there's no difference in between these two numbers, it will equal 0. So if this was a mean, this 1 would be a 0. So you'll see in this part that we have a bunch of boxes, and these boxes have lines. The box represents the effect estimate of a single study. So for this first one, the relative risk was, let's see, we'll say 0.5. The horizontal lines are the confidence intervals. And if these horizontal lines touch this middle line that is at 1, it means that the results were non-significant because it means it included 1, which 1 means X and Y are not different. Let me erase this really quick. So then we also have a diamond. And what the diamond is the average of all the effects and their confidence intervals. So the top and bottom points are the mean, and the left and right points are the confidence intervals. And we see here that our diamond crosses this middle line, meaning whatever our intervention or control was, there's no difference. So again, this just talks about why, if it's 1, there's no difference. So if the outcome of interest, let's say it's mortality, is aversive, the results are usually to the left. If the results are located to the left, it means that this occurs more frequently in the control group or less frequently in the intervention group. If the results estimates are located to the right, it means that the outcome of interest occurred more frequently in the intervention group. And usually these will have something that say like favors intervention. And then finally, with what we see here is that the diamond touches the line of no effect, which is again this middle line. Oof, I didn't write it very well there, but and this means that the combined result is not significantly different in that the overall outcome in the outcome rate is the same in the intervention and the control group. And then finally, we have to take into account the weight of the studies. Some studies are more important than others. In this particular example, this one, the second study, is the highest weighted. It's the most important study. And then finally, we have column 6, and this is the relative risk. This is actually, this number is where this little box is. So 0.5, this one's at 0.8, right here, and this one's at about 3, right here. And then the overall relative risk is around 0.8. And finally, again, these whiskers or lines represent the confidence interval. So if we look here, this confidence interval goes from 0.12, which is right about here, all the way up to 72.77. So it's hard to tell, but it would be right before this 100. So this column is saying in words what this column is saying in diagrams. And then the last thing we can look at is the I squared value. And that's usually down here. And this is the level of heterogeneity. It can take values from 0 to 100%. If the I squared value is less than 50%, the studies are considered homogeneous in that they are very similar to each other. If this value is greater than 50%, it means the heterogeneity is high, meaning they're not very similar. Studies that are not very similar are less likely to produce a significant result.